Stepwise Therapy for Type 2 Diabetes Mellitus. A structured escalating approach to managing type 2 diabetes. Intensifying treatment only when glycemic targets are not achieved at each step. Step 1. Lifestyle modification. It is the foundation of type 2 diabetes mellitus management and should begin before any pharmacotherapy is considered. In many patients, effective lifestyle changes can significantly improve glycemic control and may delay the need for medications. The first component is diet control. Patients should reduce refined carbohydrates, increase fiber intake, and limit overall caloric intake. These changes help reduce postprandial glucose excursions and support better metabolic control. The second component is physical activity. Regular aerobic exercise, along with resistance exercise, improves insulin sensitivity, allowing the body's tissues to utilize glucose more effectively. The third component is weight reduction. Even a modest reduction in body weight can significantly improve glycemic control, decrease insulin resistance, and lower cardiovascular risk. These measures form the cornerstone of type 2 diabetes management and should continue throughout treatment even after medications are started. Step 2. First-line drug therapy. After lifestyle modification, the next step in the management of type 2 diabetes mellitus is first-line drug therapy. The drug of choice for most patients is Metformin. It is started when lifestyle measures alone fail to achieve the desired glycemic targets. Metformin has remained the preferred first-line agent because it is effective, well-studied, and has a favorable safety profile. Its major action is to reduce hepatic glucose production, thereby lowering fasting blood glucose levels. It also improves insulin sensitivity, allowing peripheral tissues to respond more effectively to insulin. An important advantage is that metformin does not cause hypoglycemia when used alone because it does not stimulate insulin secretion. Important contraindications for metformin use include significant renal impairment and conditions associated with an increased risk of lactic acidosis. Step 3. Dual drug therapy. The dual drug therapy is considered when metformin alone is insufficient to achieve glycemic targets. At this stage, a second agent is added based on patient characteristics and comorbidities, allowing treatment to be individualized. One option is glimepiride, a sulfonylurea that lowers blood glucose by stimulating insulin secretion from pancreatic beta cells. Another option is sitagliptin, a DPP-4 inhibitor. It enhances endogenous incretin activity and is often chosen as a weight-neutral option. Empagliflozin, an SGLT2 inhibitor, is particularly valuable because of its proven cardiorenal benefits, making it an excellent choice in patients with cardiovascular disease or chronic kidney disease. Pioglitazone, a thiazolidinedione, improves insulin sensitivity and may be useful when insulin resistance is a major concern. Finally, liraglutide, a GLP-1 agonist, not only improves glycemic control but also promotes weight loss, making it especially attractive in overweight or obese patients. Step 4. Triple drug therapy. It is considered when dual therapy fails to achieve adequate glycemic control. At this stage, 3 agents from different drug classes are combined to produce synergistic glycemic control, meaning each drug targets a different mechanism involved in hyperglycemia. The foundation of most regimens remains metformin, which serves as the backbone of all regimens because it reduces hepatic glucose production and improves insulin sensitivity. The second component is commonly a sulfonylurea, such as glimepiride, which enhances insulin secretion from pancreatic beta cells. A third agent is then selected according to the patient's clinical profile. Options include a DPP-4 inhibitor, an SGLT2 inhibitor, or a GLP-1 agonist. These agents provide additional glucose lowering while offering benefits such as weight reduction, weight neutrality, or cardiorenal protection. The key takeaway is that triple drug therapy combines complementary mechanisms from different drug classes to achieve better glycemic control when dual therapy is no longer sufficient. Step 5. Insulin therapy. It is considered when adequate glycemic control cannot be achieved despite multiple antidiabetic medications. The goal is to progressively intensify treatment while mimicking normal physiological insulin secretion. The first step is usually basal insulin. A long-acting insulin, such as insulin glargine, is added to the existing oral therapy. Basal insulin primarily controls fasting glucose levels by providing a steady background insulin supply throughout the day and night. If glycemic control remains inadequate, treatment is intensified to a basal bolus regimen. In this approach, rapid-acting insulin is administered before meals in addition to basal insulin. This provides coverage for postprandial glucose excursions and offers more complete physiological insulin replacement. The full stepwise pathway. The key principle is treatment escalation in a logical stepwise manner based on the patient's response to therapy. The first step is lifestyle modification, which includes dietary changes, regular physical activity, and weight reduction. This remains the foundation of diabetes management. If glycemic targets are not achieved, the next step is metformin, the preferred first-line pharmacological agent because of its efficacy, safety, and low risk of hypoglycemia. When metformin alone becomes inadequate, treatment progresses to dual therapy, where a second drug from another class is added. If control remains suboptimal, triple therapy is introduced by combining 3 agents with complementary mechanisms of action. Finally, when oral and injectable non-insulin therapies fail to achieve adequate control, insulin therapy is initiated and progressively intensified as needed. The most important point to remember is that each step is initiated only when the previous step fails to achieve glycemic targets, ensuring that treatment remains proportional to disease progression while minimizing unnecessary complexity and adverse effects. Choosing the right add-on agent. After metformin, treatment should be based on individualized decision-making rather than a one-size-fits-all approach. First, consider patients with cardiovascular disease. In these individuals, drugs with proven cardiovascular benefit are preferred, particularly empagliflozin and liraglutide, which have demonstrated reductions in cardiovascular risk. Next, in patients with obesity, weight reduction becomes a major goal. Therefore, a GLP-1 agonist or an SGLT2 inhibitor is often preferred because these agents promote weight loss while improving glycemic control. For a cost-sensitive patient, affordability is an important factor. In such cases, sulfonylureas or pioglitazone may be considered because they are generally less expensive options. Current guidelines particularly favor SGLT2 inhibitors and GLP-1 agonists in patients with established cardiovascular disease (CVD) or chronic kidney disease (CKD) because of their additional organ protective benefits. Personalized therapy in type 2 diabetes. A clinical guide to selecting the right anti-diabetic regimen based on individual patient profiles, weight, hypoglycemia risk, cardiovascular status, renal function, and glycemic severity. Overweight and obese patients. Management of type 2 diabetes must always be individualized, especially in overweight and obese patients, where the choice of anti-diabetic therapy can significantly influence body weight. Let's first look at the preferred drugs. Metformin remains the first-line choice because it is generally weight neutral and effectively improves insulin sensitivity. Next are GLP-1 agonists, which are particularly valuable in obese patients because they promote significant weight loss by reducing appetite and slowing gastric emptying. SGLT2 inhibitors are also preferred as they are weight neutral to weight reducing, producing gradual weight loss through urinary glucose excretion. Now consider the drugs to avoid when possible. Sulfonylureas, thiazolidinediones, and insulin are associated with weight gain, which can worsen obesity and increase insulin resistance. High risk of hypoglycemia. A major consideration in diabetes management is the high risk of hypoglycemia, particularly in elderly patients and those with irregular meals. In these individuals, we should prefer agents with a minimal hypoglycemia risk. The first preferred drug is metformin, which has a safe, low hypoglycemia risk because it does not stimulate insulin secretion. Next are DPP-4 inhibitors, which also have minimal hypoglycemia risk since their glucose lowering effect is glucose dependent. SGLT2 inhibitors are another good option because they provide a safe glycemic profile with a very low tendency to cause hypoglycemia when used alone. Similarly, GLP-1 agonists and thiazolidinediones are often preferred over insulin in this group, as they generally carry a lower hypoglycemia risk. An important caution is to avoid sulfonylureas, glinides, and insulin whenever possible in elderly or meal irregular patients, because all can produce significant hypoglycemia. Established cardiovascular disease. When managing type 2 diabetes in patients with established cardiovascular disease, drug selection should focus not only on glucose control but also on improving cardiovascular outcomes. The preferred agents are SGLT2 inhibitors and GLP-1 receptor agonists. SGLT2 inhibitors have been shown to reduce cardiovascular events and mortality, making them particularly valuable in patients with established heart disease. Similarly, GLP-1 receptor agonists have demonstrated proven cardiovascular outcome benefits, helping reduce major adverse cardiovascular events while improving glycemic control. An important key caution concerns pioglitazone. It should be avoided in patients with heart failure because it can cause fluid retention, which may worsen edema and further deteriorate cardiac status. Chronic kidney disease. When selecting anti-diabetic therapy in patients with chronic kidney disease, we must consider not only glucose control but also renal protection and drug safety. The preferred group is SGLT2 inhibitors, which provide significant renal protection and help slow the progression of diabetic kidney disease. Because of these benefits, they are now strongly recommended in many CKD patients. Next are GLP-1 agonists, which also offer renal protection while improving glycemic control and supporting weight reduction. Another useful option is DPP-4 inhibitors, which are considered renally safe. An important point to remember is that linagliptin is the preferred DPP-4 inhibitor in CKD because it does not require dose adjustment based on renal function. Now let's discuss what to avoid. Metformin becomes contraindicated in severe renal failure because of the risk of lactic acidosis. Similarly, sulfonylureas, especially glyburide, should be used cautiously due to the risk of prolonged hypoglycemia resulting from reduced drug clearance. Severe hyperglycemia. In some patients with severe hyperglycemia, oral antidiabetic drugs alone may not be sufficient. Two important thresholds to remember are HbA1c greater than 10% or blood glucose greater than 300 mg per deciliter. These values indicate marked hyperglycemia and the need for rapid intervention. In such situations, the preferred treatment is insulin therapy. Insulin is the most effective glucose-lowering agent available and can achieve rapid glycemic control while reducing glucotoxicity and relieving symptoms such as polyuria, polydipsia, and weight loss. Delaying insulin initiation in severe cases can worsen metabolic control and increase the risk of acute complications. Early intervention is critical to restore glycemic control and prevent disease progression. Drug selection at a glance. For overweight or obese patients, preferred agents are metformin, GLP-1 agonists, and SGLT2 inhibitors because they are weight neutral or promote weight loss. In contrast, sulfonylureas, thiazolidinediones, and insulin are generally avoided because they can cause weight gain. In patients with a hypoglycemia risk, safer choices include metformin, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 agonists, and thiazolidinediones, while sulfonylureas, glycides, and insulin should be used cautiously because they increase the risk of hypoglycemia. For cardiovascular disease, SGLT2 inhibitors and GLP-1 agonists are preferred due to proven cardiovascular benefits. Pioglitazone should be avoided in patients with heart failure because of fluid retention. In chronic kidney disease, preferred options include SGLT2 inhibitors, GLP-1 agonists, and linagliptin, whereas metformin in severe renal impairment and glyburide should be avoided. Finally, in severe hyperglycemia, insulin is the preferred treatment and delaying insulin initiation should be avoided. The key message is that modern diabetes management is individualized. Drug selection depends not only on glucose control, but also on body weight, hypoglycemia risk, cardiovascular disease, kidney disease, and the severity of hyperglycemia. Drug interactions of antidiabetic drugs. Drug interactions with antidiabetic drugs may produce hypoglycemia or hyperglycemia by affecting drug metabolism, insulin secretion, or glucose regulation. Insulin and drugs causing hypoglycemia. One important cause of insulin-induced hypoglycemia is interaction with other drugs that can either enhance insulin action or make hypoglycemia harder to recognize. First, beta blockers can mask important hypoglycemic symptoms such as palpitations and tremors. They may also potentiate the insulin effect, increasing the risk of severe hypoglycemia going unnoticed. Next, ACE inhibitors enhance insulin sensitivity and improve glucose uptake by tissues, which can further lower blood glucose levels. Alcohol is another important interaction. It inhibits hepatic gluconeogenesis, reducing the liver's ability to release glucose and thereby deepening hypoglycemia. Finally, salicylates increase insulin secretion and peripheral glucose utilization, further enhancing glucose lowering. Insulin and drugs causing hyperglycemia. Now let's discuss drugs that can cause hyperglycemia and therefore reduce the effectiveness of insulin therapy. First are corticosteroids. These drugs promote gluconeogenesis in the liver and increase insulin resistance, resulting in higher blood glucose levels. This is why diabetic patients often require higher insulin doses when receiving steroids. Next are thiazide diuretics, which can reduce insulin secretion from pancreatic beta cells and thereby impair glucose control. Sympathomimetics, such as adrenaline, stimulate glycogenolysis and gluconeogenesis, increasing glucose release into the bloodstream and causing hyperglycemia. Finally, oral contraceptives may impair insulin sensitivity through estrogen and progesterone effects, leading to reduced glucose utilization. The key message is that these drugs can antagonize the glucose lowering action of insulin and may necessitate closer monitoring and dose adjustment in diabetic patients. DPP-4 inhibitors. DPP-4 inhibitors generally have few drug interactions, making them relatively safe and convenient to use. However, there are some important exceptions that should be remembered. One classic interaction involves saxagliptin and ketoconazole. Saxagliptin is metabolized by the CYP3A4 enzyme. Ketoconazole is a strong CYP3A4 inhibitor, so it reduces the metabolism of saxagliptin. As a result, saxagliptin plasma levels increase, which may enhance its effects and adverse reactions. Another important interaction is with rifampicin. Rifampicin is a potent hepatic enzyme inducer. By inducing drug metabolizing enzymes, it increases the metabolism of several DPP-4 inhibitors and thereby decreases their effectiveness, leading to reduced glycemic control. GLP-1 receptor agonists and SGLT2 inhibitors. Now, let's look at the important drug interactions of GLP-1 receptor agonists and SGLT2 inhibitors. Starting with GLP-1 receptor agonists, these drugs cause delayed gastric emptying. As a result, the absorption of co-administered oral drugs may be reduced or delayed. This interaction becomes particularly important for medications where precise absorption is critical. Another important point is that when GLP-1 receptor agonists are combined with insulin or sulfonylureas, the risk of hypoglycemia increases because the glucose lowering effects become additive. Moving to SGLT2 inhibitors. Combining them with diuretics, there is an increased risk of dehydration and hypotension due to excessive fluid loss. In addition, when SGLT2 inhibitors are used together with insulin or sulfonylureas, can also increase the risk of hypoglycemia, often requiring dose adjustment of the accompanying agent. Sulfonylureas and drugs causing hypoglycemia. One of the most important adverse drug interactions with sulfonylureas is the development of severe hypoglycemia. This occurs when certain drugs either displace sulfonylureas from plasma protein binding sites or inhibit hepatic metabolism, leading to higher plasma levels of sulfonylureas. Several drugs share this common mechanism. These include salicylates, warfarin, sulfonamides, azole antifungals, and fluoroquinolones. By increasing the amount of active sulfonylurea in the circulation, they enhance insulin secretion from pancreatic beta cells and can precipitate severe hypoglycemia. Clinically, this interaction is particularly important in elderly patients and those with renal impairment, where hypoglycemia may be prolonged and dangerous. Sulfonylureas and drugs causing hyperglycemia. Now let's discuss drugs that can cause hyperglycemia and reduce the effectiveness of sulfonylureas. A major mechanism is the induction of hepatic drug metabolizing enzymes, which increases sulfonylurea metabolism and lowers their plasma concentration. Important examples are rifampicin, phenytoin, and carbamazepine, all of which act as enzyme inducers and can reduce the hypoglycemic effect of sulfonylureas. Other drugs increase blood glucose through different mechanisms. Glucocorticoids increase hepatic glucose production and promote insulin resistance. Thiazide diuretics reduce insulin secretion from pancreatic beta cells. Oral contraceptives can impair insulin sensitivity, leading to insulin resistance. Metformin. Metformin is unique among anti-diabetic drugs because it has minimal drug interactions, largely because it is not metabolized in the liver. However, there are two clinically important interactions that every student should remember. The first is alcohol. Alcohol impairs hepatic lactate clearance, leading to accumulation of lactate in the body. When combined with metformin, this increases the risk of lactic acidosis, a rare but potentially serious adverse effect. The second interaction involves iodinated contrast media, which may cause acute renal impairment in susceptible patients. Reduced renal function can lead to metformin accumulation, further increasing the risk of lactic acidosis. Clinically, metformin is often withheld before and after contrast-based imaging procedures until renal function is confirmed to be normal. Pioglitazone. Now let's discuss the important drug interactions of pioglitazone. One clinically significant interaction occurs when pioglitazone is combined with insulin. Both drugs improve glucose control, but this combination increases the risk of fluid retention and heart failure. Therefore, patients should be monitored for edema, weight gain, and signs of cardiac decompensation. Next, gemfibrozil inhibits the CYP2C8 enzyme, which is responsible for pioglitazone metabolism. As a result, pioglitazone levels increase, potentially enhancing both its therapeutic effects and adverse effects. In contrast, rifampicin induces CYP2C8, accelerating pioglitazone metabolism and decreasing pioglitazone levels. This may reduce glycemic control and necessitate dose adjustment. High-risk combination summary. Let's conclude with a high-risk combination summary, highlighting some of the most clinically important anti-diabetic drug interactions. First, insulin plus beta blockers is a potentially dangerous combination because beta blockers can mask hypoglycemia symptoms such as tachycardia and tremors, delaying recognition of low blood glucose. Next, SGLT2 inhibitors plus diuretics can cause compounded fluid loss, increasing the risk of dehydration and hypotension, particularly in elderly patients. Another important combination is metformin plus contrast media. Contrast-induced renal impairment may lead to metformin accumulation and increase the risk of lactic acidosis. Therefore, metformin is often withheld before contrast-based imaging procedures. Finally, pioglitazone plus insulin increases the risk of fluid retention and heart failure, requiring careful monitoring for edema and worsening cardiac symptoms.